going to focus this on non-variceal upper GI bleeding, mostly peptic ulcer bleeding, and most of the discussion, let's see here, nope, no disclosures. Most of the discussion at DDW this year was really about the most recent ACG guidelines, so I just want to make sure that we give you an overview of that, and also a few of the other technologies that are coming around that are now becoming no longer, I think, experimental or investigational, and they're becoming part of standard practice that everybody should be familiar with. So looking at this, if you look at these guidelines, it's always written by the same, basically the same group of people. You sort of mix them up a little bit, and but it's Lauren Lane is going to be there, Alan Barkin, and those are going to be the main folks. And on some other ones, you'll see, Dean, or you'll see John Saltzman, or you'll see Ian Gronick. So you'll see, we'll touch base on these, but they're all fairly similar, and I'll show you how these look compared to the new ESG guidelines as well. So one of the things that each of these groups will start off with is risk stratification, and really, we talk about the Glasgow-Blatchford score. Nobody uses this on a regular basis clinically. However, the point that they're making and what they changed was that they actually said now a score of 0 or 1 point. They're sort of raising, the number of people who you can send home without doing endoscopy. And what this will do is will give you some guidance for people who come to the emergency room or people you see in your office, so you don't feel you need to admit them, and you can actually have a rational reason for not admitting them and show them these guidelines. So I think this will be useful, especially to help avoid hospitalization costs for people who really have very mild bleeding and can be managed as an outpatient. Red blood cell transfusions, I think most of us know this, but again, now the recommendation is getting stronger here, and they recommend transfusing for a hemoglobin of 7. It used to be 8, now it's 7. And if it's a hypotensive patient, then you can modify it, maybe a higher actively bleeding, a higher one. And if they have pre-existing cardiovascular disease, a higher one, probably shooting more for 8. But this is actually consistent with general data among many specialties that a hemoglobin of 7 should be your optimal threshold for these patients. Another thing which is interesting is they've gotten a little bit stronger in the recommendation to use erythromycin prior scoping upper GI bleeds. And just as a raise of hands, how many people here use erythro on a regular basis? All right, Gareth, we have a couple of people. I probably don't on a regular basis, but every now and then, if you think it's going to be a lot of blood in there, it's a good idea. And so the main advantage is it potentially improves visualization, decreases the need for second look. Endoscopy is really some of the main things here. And so the dose of it, as I've outlined here, is erythro 250 milligrams, given over 5 to 30 minutes prior to the procedure, followed by the endoscopy roughly an hour later. That's going to be your general thing. Be careful for people who have a history of prolonged QT or at risk for prolonged QT intervals. So, these recommendations, and many of the studies have avoided it in those patients, so I think you have to individualize. And again, this is now they've changed the recommendations here to suggest. It's not, not recommend, so it's a little less strong than that, but just suggesting as opposed to should be considered. For PPIs, it's interesting. This is, a constant debate about whether or not you need to start PPIs right when people hit the ER, and they couldn't come to a consensus on this. They could not make a recommendation for or against PPIs in the ER, although commonly they are started in the ER. We know from the Laos study from 2007 that you see here that if you put somebody on PPI when they go into the emergency room, and then when you scope them, you'll actually shift the endoscopic stigmata to stigmata that need fewer endoscopic interventions. So you'll start that healing process. But whether or not that really changes the outcome is unclear. And I think that the reason and the rationale that many of us will use PPIs when they first come in is you don't really know exactly when you're going to do that endoscopy. There may be some delays. And some of the conditions, adherent clots and non-bleeding visible vessels, actually can get treated quite well with PPIs alone. So it's, again, the point of this being you can probably go either way on this, and you'll have guidelines to support you that there is no recommendation. Now, what about the timing of endoscopy? Because again, like I said, you don't know when you're going to do that endoscopy. And there's been two studies, one from Hong Kong and this one from Scandinavia, in which they look at the timing of endoscopy, when you do that endoscopy for an upper GI bleed, and what the mortality is, so basically the outcome. And you can see it's a U-shaped curve, and that if you do the endoscopy too soon, there's actually higher mortality. And if you do it too late, the mortality starts going up. And so there's a sweet spot somewhere in here at around 10 to 30 hours is your sweet spot. And the reason is if you scope someone too soon, they're under-resuscitated, you can get into problems with that. If you wait and delay too much, then you may have missed your window to do some intervention to do hemostasis. So they look at this type of data, and the upper curve here is the sicker people. So the more sick the person is, ASA 3 to 5, the more pronounced this is, and the real mortality exists. The lower ASAs, it's a little less pronounced. And so in terms of the timing, what they are saying is that the suggestion is that anybody admitted to the hospital undergo the EGD within 24 hours. Why is this important? Because if you're covering the hospital at night, you're the hospitalist, it doesn't mean you have to run in for every case, within 2 hours or 4 hours. Sometime in that next 24 hours is when you should do it. And often you want to do it when your best team is around, so it's safer for the patients. One of the Hong Kong groups did a nice study. Again, the Lao did this in just last year, in which they randomized patients to get scoped in less than 6 hours of presentation to the ER versus 6 to 24 hours. And what they found was that there was really no difference if you did it an urgent early endoscopy versus waiting a little bit, for that 6 to 24 hours in terms of any of the usual parameters and outcomes we look at. So again, just to emphasize to your colleagues, you don't have to do it right away, stabilize the patient, then scope them, but don't wait 2 days. This is our endoscopic stigmata. We've seen this from Dean and others for a long time in terms of what the rebleed rates are if you do no therapy and no PPIs. So these are your high-risk lesions, especially arterial bleeding and non-bleeding visible vessels. And so, what do they recommend in terms of hemostasis? If you have, either one of these high-risk stigmata, they recommend all of those high-risk stigmata do get treated, arterial spurting, visible vessels, and we'll talk about adherent clots. They also recommend oozing to be treated as well. And so this is just looking at clots and shaving this down, and something that we'll talk about here in a minute, whether or not you need to do it or not. What their recommendations, are for the adherent clots was actually that they couldn't come up with a final recommendation. Actually, this goes way back historically to Dean versus Warren, in which Dean would say you gotta remove the clots because if you do, the improvement is so obvious. While Warren would say, if I irrigate it super hard and that clot doesn't come off, that clot was meant to be there for a purpose, leave it alone. So, we're still in the same thing. The data isn't really playing out one way or the other. A lot of it really depends on how hard you're trying to get that clot off. And also the use of PPIs, especially high-dose PPIs, has really changed this because it really does start healing things out. And the most recent Annals of Internal Medicine, or one of the best done Annals of Internal Medicine studies by Sung, really showed that if you did high-dose PPIs, there wasn't a difference between taking off the clots or not. Oops, sorry. And then, we're going to skip that. And then in terms of what do you recommend for just your typical high-risk patients with active bleeding, visible vessels, they recommend the usual things: bipolar probe, heater probe, or injection of absolute alcohol, which I would recommend don't using, but there is data which would support that. They suggest, so a little bit less strong recommendations for clips, APC, which is new, or soft monopolar electrocoagulation. We'll talk about that. They recommend don't use epi alone, although in reality, if you look at the studies, epi alone is better than nothing, but they recommend use epi plus some other therapy, again, usually either thermal or clips. They now suggest that you can use hemostatic powder spray, the TC325, in patients with actively bleeding ulcers. So it's a suggestion. And they do suggest also that you can use over-the-scope clips as hemostatic therapy for patients who develop recurrent bleeding due to ulcers after previous endoscopic hemostasis. So they're starting to pull in some of these newer modalities. And so hemostatic forceps You can see here, we've seen several talks today showing how you use these during POEM. If you see a bleeding, you can grab the vessel and then you apply coagulation with the clip. And here you can see from Raju, one of his studies, it's actually in the colon, but you can see down here you apply the clip, the hemostatic forceps, you actually grab the vessel, you can squeeze on top of it, and then you'll retract back just a little bit so you can get a little bit of area. Then you'll apply pressure 1 or 2 second pulses to get some coagulation, and then you open up your forceps. And if you have a very focal vessel that's bleeding, this is a great way to stop this bleeding. So it doesn't, this can actually be on ulcer bleeds and others. So this is one of those tools you should probably have in your armamentarium. These are different than hot biopsy forceps, so you're not going to be tearing off or avulsing things, but it's a nice new tool to have in your armamentarium for regular GI bleeds for those occasions. And also if you're doing polypectomies, you're doing other things in which you need something and you actually see that vessel bleeding. Hemostatic powder, the TC325 spray, has been around for several years now and working its way through the trials, and what it will do is going to be absorb water, it concentrates cells, improves clotting. You can see down here in the bottom corner, you prime it a couple times before you use it. Here's active bleeding. This is a bad, vessel, which is bleeding. This is one of Alan Barkin's videos, and here you can see the probe out. It's going to start just spraying over this area. The delivery catheter is 1 or 2 centimeters away. You spray it, and then what will happen is you'll cover the area, and then you'll get absorption of the water and the concentration, and you get this kind of surface coating which will form on top of it. It only works in active bleeding, so you have to have that fresh blood there, and it actually will start precipitating out and start forming this this coagulum with water, so everything has to be quite dry when you do it. The nice thing about it, relatively easy to perform. Downside with it is somewhat expensive, although there are some pass-through codes for certain payers. One of the important studies that is mentioned frequently is not from this DDW, but from last DDW. And this was from the Hong Kong group, the Lao group again, in which they took 224 patients, they randomized them to this spray therapy, the hemostatic powder versus the clip or the probe coagulation. And when they looked at this, what they found was the rebleed rate at 30 days was the same. So it didn't, so using the powder versus using standard clips or other endoscopic therapy, actually there was non-inferiority between the two. And so this is a little bit different, and this is why they now recommend that you may consider using this as first-line therapy for bleeding ulcers. We're still waiting for this paper to be published, but I suspect it will be published sometime in the next few months, in which case this may add another tool that you can use for treating GI bleeding, especially from peptic ulcer diseases. It's effective and very effective for tumor bleeding and other things, and not just for temporizing, but maybe even a little bit better. So I think we'll be hearing more about this, again, the cost being somewhat of an issue still. Over-the-scope clips is another important advent. We've talked about it a little bit today, but maybe not as much as in, if we were talking more about things, doing, in the stomach or in the colon, but these, or closing holes, but these are clamps that go over the scope that we really use for tissue opposition. We often use for perforations and other things, but you can also use it for hemostasis for vessels. And so here, you can see, this is from John Saltzman. This is a big ulcer that you have in the stomach. There's this huge vessel in there. And what you can do is you suck it in. This is also something very easy to do. If you can do banding, you can do this. You just aspirate in the area that either bleeding or the non-bleeding visible vessel. You turn the crank, and then you'll see that the over-the-scope clip or clamp will deploy. And there's 2 companies that make these now, and you can, and there you can see grasping with very good closure of this defect. So again, this is another one that's relatively easy to perform, certainly within the skill set of most gastroenterologists. And when you look at the data, the STING study by Schmidt and Gastro from now 3 years ago, what they did is they looked at people who had recurrent bleeding. They'd had one episode of endoscopic therapy, and then rather than what we would typically do is do another episode of standard endoscopic therapy, they did, okay, either you get standard endoscopic therapy or you get an over-the-scope clip. And then they also did a crossover if you failed standard hemostasis. And the primary endpoint was rebleeding at the second episode. And what they found was that, for people who had rebled once with standard therapy, it's a fairly high number, so it's a little, I kind of question that. About 50% plus had more rebleeding versus 15% with the over-the-scope clips. So the idea being here is that this is definitely something in your toolkit that you may want to use, especially for these rebleeding, and I would say even potentially for severe primary therapy for certain conditions, because again, we're seeing it can be done safely, effectively, and relatively easily. Again, there is a cost to this as well. When you look at the, Dean and Tom Kovacs, looked at this as initial treatment for non-variceal bleeding. And this was using an over-the-scope clip versus standard therapy. And what they found is that for further bleeding, they had a big difference here. It was 4% versus 29%, and there's also fewer complications. And so at least in Dean's study of a randomized controlled study, there's a suggestion that this may actually be better than standard, clips or bipolar probe. I think we need more studies before I would say that this should be part of the initial treatment, but clearly the studies are coming out, and it's going to be interesting to see as more of these are published. Now, the next thing was, what about PPIs after endoscopic hemostasis? They do, this is a controversial area now, and the controversy is a couple things. One is, do you need IV or can you use PO? And that's, and do you need continuous versus intermittent? And so that's what these folks are addressing. So they're recommending use high dose, and they're saying you can do continuous or intermittent. They're not coming down on one way or the other, and they're saying you can do oral or IV. So the data is not that strong that IV continuous dose for 72 hours is critical. And I know at least in our hospital, when our internal medicine folks look at our hospital medicine, they push us on this. They say, look, the data says we can use intermittent, we shouldn't use continuous dosing, and they say, why are we not switching to orals quicker? So again, keep that in mind, because I think most hospitals are struggling with this. They also suggest that people who get endoscopic therapy, the high risk, should be on a twice daily PPI just for 2 weeks. They're saying for 2 weeks. It used to be 4 weeks, 8 weeks, 10 weeks. 2 weeks on a twice daily high dose, and then you can switch down to once a day. So we're starting to adjust the PPI dosing that folks are needing after endoscopic hemostasis. And again, that's what this one shows. Recurrent bleeding, the usual, in general though, if you have recurrent bleeding after endoscopic therapy, you repeat the endoscopic, some sort of endoscopy. It could be over the scope clip, it could be regular, and then if that doesn't go the third time, you'd go to IR. And then if you keep on failing, it's the same one. Oops, sorry. And then when Ian Gronick published his ESGE, same thing, update in 2020. And the only other things, they were identical to the ACG ones. The only thing they said was they talked about aspirin, NSAIDs. If do not stop low-dose aspirin for secondary cardiovascular issues if people have stents, and they recommend restart anticoagulation as soon as possible. They said within 7 days. I think we usually try to do that with cardiology. Finally, what about the other devices that are out there that at least you should be aware of? One of them is Doppler probes. If Dean were here, we may have started with Doppler probes, but it is, Doppler probes they're interesting. Dean has this gastro paper, again, from the same hemostasis group. Gareth, you're on this one too, so you've used it, and they definitely probably have a role. You can see, try to trace which direction the vessel goes. You can do your treatment until you no longer have a signal, and at least looking in Dean's study, there was a significant difference in terms of rebleeding if you use the Doppler assisted versus the standard therapy. So it's something out there. I don't think that, just raise a hand. Is anybody using this? Does anyone have this in their unit? Gareth does, thank you. So it's probably as good. You're on the spot. And, but some of the folks also at the sessions on variceal bleeding for gastric varices doing EUS-guided therapy or other therapy are suggesting using a Doppler probe may actually help out for those. So it still may be, I think it may just be slow in coming, but I think it actually may be coming. Endoscopic suturing, this is a case of from our unit for Wilson, Kong, and Ed. We've seen endoscopic suturing done today in a variety of talks. You can use that to close bleeding ulcers as well. So something that for those centers who use it to keep in mind. Usually you don't need this, but you could do it. EUS-guided coil embolization, we talk about this more for variceal bleeding, for gastric varices, in which we inject into it. We put in some of the coils that the IR folks we use for embolization, and those can be used for varices and for other bleeding as well, including some non-variceal bleeding. So, in conclusion, this is just an update. Most of us are doing these things, but just to remind us, you want to do those endoscopies in the sweet spot, probably between 6 and 24 hours. Continue IV or consider it in some of the people with severe upper GI bleeding. It may help you in terms of getting better visualization. Continue to do your standard therapy in terms of clips and bipolar probes for treatment, but you should learn how to use some of the over-the-scope clips, the hemostatic sprays, and the coagulation grasping forceps, because these really are going to start becoming part of your toolbox for these. And just continue to familiarize yourself with these different guidelines that are coming out. So thank you for your attention. Oh.
The elephant in the room, Kovacs and your efficacy for various treatment protocols. We see people every day who come in, they just took their Eliquis 12 hours ago. What do? Do you try to delay 24 hours, 36 hours to eliminate efficacy from lack of, most of the treatments revolve around platelet function.
Yeah, so the question was about DOACs and whether or not you delay your therapy. I would say if they come in with a GI bleed, you're going to put them on PPIs. I'm probably not going to, the heart always works, but we can get down there and you can use clips, you can do physical, you can still help the people, but I can't overemphasize how important the IV or the interim PPIs are in actually decreasing the bleeding for most of these people. Do that plus the clips, you still may be able to continue the DOACs. So I think that's kind of what Ian's getting at, but that's going to be a selective one. So, yeah. Generally speaking, we talk about vessels 2 millimeters or more to be very difficult to close, but these are usually going to be 1 or 2 millimeter vessels that we're talking, similar to what we're seeing when we're doing ESDs or POEMs, and those are going to be the size. If you see a big gastroduodenal artery that's pulsating, don't use the hemostatic forceps. That would perhaps an over-the-scope clip, but not a hemostatic forceps. Yeah, Sam.
Yeah.
Yeah, if it's a huge duodenal ulcer and you may just have to do clips. You may be able to do the clamps, the over-the-scope clips, but those sometimes get difficult because they can be, and those are challenging. So it's not always super easy for those. No, but I totally agree. So we're gonna go to the next speaker. Sorry, but thanks for your attention. And so for our final speaker of this